So I apologize. I misspoke.
It's in the chat.
So, but we'll revisit it after the break. Because I want to look at it.
I just don't want us to
No.
rush.
Well, I'm glad you all reminded me of that. I guess in ahead of my head we moved it, but I'd forgotten where exactly we moved it. Okay, so this chapter talks about labor and birth processes. And by processes, I mean just I don't want to say manual processes, but a little bit more of the mechanics of labor and delivery. The next chapter, chapter 14, is pain in labor, pain and comfort, basically, is the name of that chapter. Neither one of these are really long chapters. I brought a few props with me because it always helps to be able to see and visualize what we're talking about. Those of you guys who've been in clinical and filled out some of the paperwork in OB have seen that there is a whole section at the end of the OB paperwork that says stages of labor. And so with some of you all, I've talked about stages of labor. So we're going to go through that today and talk about stages of labor, what that means. And then when we get to chapter 16, we'll talk about it in more detail. Basically, chapter 16 is taking each stage of labor and talking about what happens during each stage of labor. And this is just the labor and birth processes as a general rule. So 5 factors that affect the process of labor and birth. There are the 5 P's of labor and birth. I know in the second semester you learned the 5 P's of a neurovascular assessment, right? Pulse, paresthesia, paralysis, all that good stuff. Now here's a different 5 P's of labor and birth. So you're just going to have to kind of get in your mind, are we talking about a neurovascular assessment? Are we talking about the 5 P's of labor and birth? What 5 P's are we referring to? In this case, it's the first P is passenger. The passengers are the fetus and the placenta. Those are the 2 passengers in this process. The second P is passageway, and the passageway is going to be the birth canal, the way that the fetus exits the body. The third P is going to be the powers, and the powers are the contractions. What is the power that propels the fetus out? Maybe propel is the wrong word, because it's more like inches out instead of propels out. Position of mother. If you have not heard me talk about it before, you're going to hear me talk about it today. The importance of maternal position in terms of labor and delivery and the success of the ability for mom to deliver. And psychological response is the last P. So we're going to hit on each one of those in detail and talk about what they mean. And psychological response really just looks at the mom's frame of mind. You know, there is certainly a component to labor and birth that takes into account the psychological state of the mother. For example, if we have a mom who has been the victim of a sexual assault and has had a very difficult, and I'm not talking about maybe related to pregnancy, but just even in the past at any time, that changes their perception of the birth process. It changes their perception of how it feels to have multiple people in the room when they're exposed in a very vulnerable way, and it really affects their progress sometimes. Literally affects their progress of labor. Hopefully we know about if the best situation is the one in which we know about the patient's past and we can address it. Also, if you think about dealing with a teenager, let's say you're dealing with a 15-year-old. How scared, how afraid, how nervous is that 15-year-old going to be? How is her fear and anxiety going to affect her labor and delivery experience? Or just maybe a mom who's just a really nervous, some people are more nervous than others, but your anxiety and your psychological state most definitely have an impact on labor and birth. I've seen patients who got so worked up. Usually, you've probably all heard me say several times that epidurals tend to slow down labor, and for the most part, they do not speed the process up at all, even though they do provide a lot of comfort. There are a few exceptions. There are a few patients who get so keyed up and so nervous and so tense that if you give them something that relaxes them and they just, kind of take a breath, all of a sudden they're ready to have a baby. They're, fully dilated, ready to go, and they needed some relief from their psychological state. So it most definitely has an impact. So we'll touch on that as well. So the first one, passenger. What factors affect the passenger? Well, the size of the fetal head. Obviously, the whole thing about labor and birth is and obviously babies don't have a purple onesie on. I always like to use this fetus because it has the this baby because it has the little fontanelles on the top. And so it helps me, it's much easier to kind of tell what's what. So if this is our fetus, this is our pelvis, okay? So the whole thing is a dance between the size of the head and the size of the pelvis, right? If the pelvis is too small for the head, or the head's too big for the pelvis, whichever way you want to look at it, you got a problem. Baby's not going to fit. So we have to look at the size of the head compared to the size of the pelvis as number one. That's the first issue. If the whole baby is a very large baby and the mother has a average or small size pelvis, you have a problem. Or if the mother has a decent size pelvis, but again the baby's very large, maybe it's a diabetic baby or something, again you got a problem. But sometimes the case is not that the head and the pelvis don't match. There's a term called cephalopelvic disproportion. And you'll hear me say that probably again and again in the next few chapters. So cephalo meaning head, pelvic disproportion, or CPD, often known as CPD, cephalopelvic disproportion, essentially means that the head and the pelvis, there's a disproportion between the size and it doesn't fit. So this head, you will see, if I take the pelvis and I try to push it just like this, straight down like that, it doesn't fit, does it? Now what if I do this? I will tell you when it gets down to here, it will all come out, but just for meaning, just sake of example, if I turn the head this way, it will fit in the pelvis. So sometimes it's not the cephalopelvic, ratio that's the problem, but it's the position of the head. If the head is in a different position, the head would fit. Whereas if it's turned a certain way, it won't fit. What if the baby was what we call a brow presentation or a chin presentation, meaning the head's flexed back like that, coming first? There's no way that's going to fit. But if the head is nice and tucked like it's supposed to be, turned to the side like it's supposed to be, it will fit in the pelvis. So the whole thing is a dance between the size of the mom's pelvis, the size of the baby's head, and then the position of the baby in the pelvis. Those are the two big factors that are going to affect whether the head's going to fit. So size of the fetal head, number one. Fetal presentation, what part is presenting to the cervix? So what if, on the other hand, the head's not presenting, but what if the butt is presenting and we have a breech baby? Not likely to fit either. Or what if we have what we call double footling breech? It's coming out this way. Okay, turn backwards. So again, you see all those different presentations are going to impact whether or not the baby's head fits. If the feet are coming first, the butt's coming first, or what if the baby's laying like this? Here's the mom's pelvis. Here's the mom standing here. Baby's laying transverse. Is that baby going to come out vaginally? How? No. No. This is that's going to be a C-section for that patient, for sure. So the fetal lie that's what I just showed you. How's the body laid? Is the fetal body laying vertical with the pelvis? Is it lying horizontal? Or is it what we call transverse, in which it would be kind of like that? Again, that's going to impact whether or not the baby fits. And then the fetal attitude, what we call attitude, is not the attitude like you think of a bad attitude. The attitude is either flexion or extension. So if a baby's flexed, think of what do you think of when you think of the fetal position? Think of somebody all curled up in a ball right around themselves. That's the fetal position, is flexed. So your baby in utero is all flexed around themselves, and then it's just like this, and then as they come down through the pelvis, their legs will straighten out at the end. But flex is what we want. We want the head and neck flexed because we want this part of the baby, the occiput, see this is the occipital bone right here, right? This is the posterior fontanelle. We want the occipital bone to present first. In a perfect scenario, in a birth that is positioned like we want to see the occiput presenting to the cervix. That's what should be coming out first. If it's the brow, the chin, the face, or anything else, you're going to have a problem. Not to say that mom can't deliver the baby. I've seen a few moms deliver a baby that were brow presentations or face presentations, but that mom's going to have a very large pelvis, and maybe have had several babies before in order to accommodate a baby that's presenting in such an unusual way. So we had a baby, I think it was last semester, I think it was this semester, that was born via face presentation, and the mom did have a vaginal delivery, and that baby's, everybody was going to look at the baby because its face literally looked purple and black. It was because it was bruised. So in order to assess that baby's oxygenation, you could not look at its face because you would think that baby was dead because it was all blue, purple, almost black looking from bruising, from that face presenting for such a long period of time to the cervix. But the mom had had large babies before. This wasn't a large baby. She was able to have that baby vaginally. That's very unusual. Usually, if anything is presenting besides this area of the head, the occipital area, you got a big problem. And then fetal position is what I just told you. OA would be occiput anterior. OP would be occiput posterior. Brow is synciput, which is what I just told you. This is the brow. Mentum is a chin presentation. Now, what we want, when I say OA and OP, this is real important that you understand this because this is the most, now we're getting down to the details of the presentation. First is the head coming first. That's the first thing we're going to know is the baby coming head first, right? The baby's not coming head first, we're looking at a C-section. So is the head coming first? That's number one. And then will the head fit through the pelvis? Is there cephalopelvic disproportion or not? Is the head too big for the pelvis? That's the next thing. After that, we look at how is the baby laying. Is it laying transverse or, or this is really what we call oblique when it's sort of not quite somewhere in between this way and this way. It's called oblique, transverse, or actually coming straight down vertical like it should. And then the attitude, of course, should be flexed. And then the last thing is OA or OP. What does that mean? The O is for occiput. So remember I said we want the occipital area coming first, right? This is what we want to see coming first. If this is the cervix down here, then the occipital area should be right coming in contact with the cervix. Now, you got two possibilities for that occipital area. And this is what's important to remember. This is what happens more than anything. And this is what happens when a mom gets in bed and doesn't move. So what we like to see is what we call OA or occiput anterior. That means the occiput is anterior to the pelvis. So this is the front of the mom's pelvis, right? The anterior pelvis. The occiput is facing it. So if the baby is to be born like this, the baby is essentially going to be come out facing the floor. If the baby's turned like this, on the other hand, the occiput's facing, that's true, but it's occiput posterior. And now the baby's coming out, and if it would be more like this, it would literally come out looking up at the ceiling. And that's called posterior. The doctors call it sunny side up. When the baby comes out looking at you, looking up at everybody, they'll call it sunny side up. That's occiput posterior. What's the problem with that? Well, it makes the diameter of the head larger in relationship to the pelvis in that position. So occiput anterior is the best way for the baby to come out. So the baby's head does turn a little bit, but then as it's being born, it turns and faces down. But occiput posterior, on the other hand, is when the head can be turned a little bit, but the body is facing up. So the occiput, in this case, is facing the mom's posterior. So either the baby's occiput anterior, which is what we want, meaning the occiput's facing the mom's anterior, or the baby's occiput posterior, meaning the occiput is facing the mom's posterior. Everybody get that?
Yeah, you said it make the diameter of the head larger in comparison to what?
We want it to be occiput anterior. It's the smaller diameter to pass through if the baby's presenting occiput anterior. That's the desired position.
So basically in comparison
to posterior. Yes. The diameter in comparison to the pelvis is smaller for the head compared to the pelvis if the baby's anterior versus if the baby is posterior. Well, anterior, posterior. The baby's coming like this. The baby literally is going to be born, looking up, come out, looking up at mom. That's posterior. Can they be born like that? Yes. We see it from time to time. And fairly frequently, if the mom's pelvis is big enough. But again, if you've got a mom who's got a marginal pelvis, or it's her first baby, she's never had a baby before, it's going to make it a lot more difficult to get that baby out. Maybe she can push out a 6-pound, 13-ounce baby posterior, but maybe not an 8-pound baby posterior. Does that make sense to everybody? So If I asked you on a test question, if I said, the patient, or just a straight up question, the most desired position for the fetus for birth would be occiput anterior. Occiput anterior. Occiput posterior meaning the occiput facing the mom's posterior. And the baby's going to be looking face up, and that's the least desirable way, the less desirable way for a baby to be born in terms of the proportion comparing to the head to the pelvis. Everybody with me? Questions about that? Okay. So, what would cause the baby to get in that posterior position then? Why would it get like that? You may have any ideas what would cause the baby to get in a posterior position? Mom's position, exactly. So when we put our mom in bed and she doesn't move, put her in the bed, put monitors on her, start giving her pain medication, say you can't get up. The baby tends to get in that position. And it's hard to get the baby out. And so how do we get the baby out of that occiput posterior position and get the baby to turn? Move the mom. You'll learn when we talk about fetal monitoring. We can't move our baby. I can't get to my baby to move my baby. So the only way to move my baby is to move my mom and hope the baby responds. So we'll put that mom, if we can, once we establish that the baby's occiput posterior. And the way we establish that is by doing an exam and feeling where the occipital bone is. And so a well-trained nurse or physician can feel the occipital bone and tell which way the head's facing. So if we determine that the baby is in an occiput posterior position, we want that baby to move. So if we can, we'll have our mom walk. We'll have her move around, change positions. We have those birthing balls that we give patients. Something about that birthing ball tends to cause babies to turn. It works very well if we can do that. Now, if my mom has an epidural and she's relatively numb from the waist down, I can't do any of those things. All I can do is flip her like a pancake every 30 minutes. Left, right, left, right, left, right. Can't do any of those things. So that's where an epidural can be a disadvantage. Does it give you good pain relief? Yes. Does it cause you to be not able to move the mom like you'd like? Yes. So that is a definite disadvantage of that kind of anesthesia because you can't move the mom like you'd like to. Okay, and so a lot of these slides are just pictures of the different bones I showed you. Of course, where the occipital bone is, and these are all the bones of the fetal cranium. And as you can see, all these are not fused together yet. None of those bones are fused together in the fetal head. Why is that? Why are these bones still in pieces?
So it can move as it's going through the...
So it can mold and overlap, if necessary, to fit through the pelvis. And that overlapping of those bones is called molding. M-O-U-L-D-I-N-G, molding. Molding is when the bones overlap so the baby can come out. If the bones mold or overlap, then in 2 or 3 days after birth, it just goes away. So it's a very normal occurrence. If you ever get to see any in the nursery, it feels really weird because you can literally feel the overriding sutures where they override each other. So this is how the fetal cranium is formed. So hopefully to be able to fit through the pelvis. Well, the cone head is soft. There's 2 different things. I'm glad you brought that up. The cone head, when you see a baby with the cone head, that's more of a soft tissue. Some swelling up here and soft tissue where it gets kind of stuck in the pelvis, or what maybe they use the vacuum. So that's more of a soft tissue thing. But the overriding sutures, literally you can feel the head and feel bone over bone. That's molding. So caput, C-A-P-U-T, caput. And you need to remember both those terms, caput and molding. So caput is the soft tissue where the cone head, where the baby has cone head. And then the molding is when you have overriding bones that kind of override each other so that the baby can fit through the pelvis. Those bones, because they're not fused together, can literally move and kind of do this to make the head smaller to fit. Sometimes the head still doesn't fit, even in spite of the fact that happens. Sometimes it still doesn't fit. So here's some pictures of the different positions. Now, so I talked about OA and OP, occiput anterior, occiput posterior. I don't want to throw you off by this, but you will often hear us say LOP, ROP, and basically what we're going to talk about is which way is the head tilted? Is it left or right? Don't worry about that in terms of testing, but all the, if there's an R or an L in front of it, it basically just means, the head, instead of coming straight down, it may be tilted to the left, it may be tilted to the right, and that doesn't really make any difference left or right. It's more about anterior, posterior. But this baby, you can see, essentially this baby's back is towards the mom's back. So the posterior of the baby is facing the posterior of the mom's pelvis. So this is turned slightly to the right, so that's right occiput posterior, left occiput posterior. This one's, the baby, is essentially facing the other way. The occiput area is facing the mom's anterior, but it's turned slightly to the left or right. And transverse basically just means it's kind of somewhere in between. So don't get caught up in the left or right or transverse. Just think about OA and OP. So the lie of the fetus is either longitudinal, the fetal lie, longitudinal like this, or vertical. If it's vertical like this, we're good. If it's like this, we're going to be able to C-section. Presentation, vertex is head. What's presenting to the cervix? What's coming first? We want it to be head. Reference point, occiput. What part of the head is presenting? The occipital area, which is what we want. Then the attitude that we want is general flexion. So the baby could be doing everything else right, but if the flexion's wrong, again, it could be coming down as it should, but instead of the occiput presenting, again, if it's the face or the brow, you got a problem. So I've also seen babies that have an arm like this up beside the head. So the head's coming down like it's supposed to, but the arm is right up here like that. So that really interferes as well. 9 times out of 10, that patient may end up having a C-section because the arm gets in the way. We're worried about the mobility, damage to the arm, so that can happen as well. Here's different kinds of breech non-vertex presentations, most of them are breech. Frank breech is this. See how the baby's feet are up by the head? That's called frank breech. Most of the time, if the baby's going to be breech, this is the breech you're going to see. So, as far as longitudinal or vertical, it's longitudinal. It's vertical. As it should be, it's vertical. It's up and down. Presentation is frank breech. Presenting part here is the sacrum. And the attitude, the baby is flexed except for the legs and the knees. Now, over here you have single footling breech, meaning the foot's coming first. You can have single or double footling breech. Here you've got complete breech. When the baby's sitting Indian style like this, that's called complete breech. And then right here, actually, this is a shoulder presentation. Is that baby ever going to come out? This is a baby that, in 1910, mom and baby would have died. Unless they were able to get somewhere to do a C-section. If they could have got to a hospital to do a C-section, maybe they would have spread. But that baby has no chance of coming out. Some of these babies would probably not do well either, but they at least have a shot of getting out. Probably not, maybe not this one. But the breeches you might possibly be able to get out. As a matter of fact, frank breech is the only, which means the butt is presenting. And the butt kind of mimics the behavior of the head when the feet are folded up like that. It's called, and the baby's coming frank breech. I have seen frank breech deliveries, vaginal deliveries. Doctors don't do it anymore because of legal issues and concerns about the baby. But I've seen many frank breech deliveries. And probably, when I first started working, some doctors would still do a frank breech delivery. It's the only one that's considered possibly safe for a vaginal delivery, but any other breech is not. The concern with any breech birth is that you get the body out and then the head. How do you get the head out? Any of you all watch the TV show called The Midwife? They do a lot of breech deliveries on that show. I mean, I know it's obviously a TV show, but they do a great job at it being really real. And they had a procedure on there. They talked about one show about how they do breech deliveries to get those babies out because they're very difficult to do and they can be dangerous. Because of the legal climate that we live in now, we do not, no doctor that I know of does breech deliveries of any kind. They do C-section. But if there's one that is safe for a vaginal delivery, one that's possible, it's frank breech. That means the feet are up by the head and the butt's coming first. So in the world, just to kind of give you a reference point, 95% of the time babies come head first. 95% of the time. 4% of the time they come frank breech, and 1% is everything else. So that really kind of gives you a bit of a reference as how often you're going to see a baby in one of these weird positions. Not very often. So, I mean, that's not testing material. That's just to kind of give you a frame of reference. And then again, you see the diameter of the head here and where this is also going to come into play. So you see here where we have the size of the pelvis over here. We have a brow and chin presentation, and then we have a regular vertex presentation. And it shows how big the diameter of the head needs to be to accommodate each of these presentations. So a regular normal vertex occipital, 9.25 or 9.5 by 9.25. Over here it has to be, you've got to have a pelvis of 12 centimeters by 9.25. For a brow, you've got to have a pelvis of 13.5 centimeters by 9.25. So you see how much bigger your pelvis has to be to accommodate these sort of presentations. Their head, yes. This one's brow. This one's, actually that one is not chin. I don't know what that is. That's mislabeled. That is not a chin presentation. But the top one is the actual occipital presentation. That's a typo in the middle.
I think chin was momentum. Is the brow syncopate and the chin is momentum?
Well, it's mislabeled then. They're both, it's a syncopate and brow, which are essentially the same thing. So it's yeah, you're right, the chin is mentioned, but it's mislabeled because the syncopate and brow are the same thing. Anyway, the point being that you can see with different presentations other than what we want, which is occipital, what the diameter of the pelvis has to be. It has to be much bigger to accommodate that. So if you are a woman who does not have a pelvis that size, you're going to be in trouble in terms of being able to have a vaginal delivery. Okay, so here's our pelvis. Just like this is our pelvis right here. I think I told you all back on the first day, or when we talked about the anatomy, that I talked about the ischial spines, right? I said, don't forget that. Okay, so now we're coming back to the ischial spines. Here are the ischial spines. I've got the pelvis upside down so you can see it. Here are these little things that are coming inward. So if we look at the pelvis, if you look at it this way, you can see as those ischial spines come inward, that makes the pelvis more narrow. So the narrowest most point of this pelvis is going to be at the ischial spine. That's the most narrow area. So you got the wide false pelvis up here. You got the more narrow true pelvis down here. You got the sacrum and coccyx here. And you got these ischial spines. So a lot of people ask, well, look at that coccyx, how that protrudes in. Why doesn't that prevent the baby from coming down? Because the coccyx is only attached by cartilage, and if it gets in the way, what did I tell you happens? It just breaks. Yeah. And it repels, repairs itself and it's not treated in any way, it just breaks. Just painful, uncomfortable, and you can usually hear it most of the time if you know what you're listening for. You hear it crack. So what we're worried about are these ischial spines. So that's why the area of the ischial spines is called zero station. When we talk about a woman's exam, when she's in labor, everybody thinks about dilation. We talk about dilation of the cervix. Then we talk about effacement, or the thickness or thinness of the cervix. And then we talk about the three things: station, dilation, and effacement. Station, dilation, and effacement. So the station is where's the baby's head in relationship to the ischial spine? Where's the head? If the top of the head, and we're talking about, if the top of the head is right here at the ischial spine, it's zero station. So it's at the most narrow point it's got to get to. Once it passes zero station, the odds are getting better and better that the patient's going to be able to deliver the baby. So if you can't get the head to come below -1, you got a problem. And that means the head's above the ischial spine. So if the head's above that ischial spine, it's in minus territory. If the head is below the ischial spine, it's plus territory. Plus meaning it's closer to getting out. So up here, minus, down here's plus. +1, +2, +3, +4 babies on the floor. That's sort of an expression to help you remember. Because somebody's not there to catch the baby on the floor. Let's put it that way. So, baby is being delivered at +4, coming out of the body. So when we examine someone, we feel where the ischial spines are, and then where is the fetal head in relationship to it. If it's a centimeter above it, it's -1. If it's a centimeter below it, it's +1. We're talking about this part of the head as it's coming down. Where is it? Everybody understand that? Okay. So zero station, again, the narrowest, most point of the pelvis, it's where the ischial spines are. That tells us where the head is in relationship to that pelvis. As it gets in the most narrow area, it's concerning to us if the head does not descend past zero station. Okay, so that's the passenger. And passageway we've hit on a little bit too. The passageway, or birth canal, is composed of the bony pelvis, which we talked about. That certainly is a factor. The patient's pelvis is most certainly a factor. Especially if she has very prominent ischial spines, it could become more of a factor. The cervix, is the cervix dilating as it should? The pelvic floor muscles, the vagina, and the introitus, or the external opening to the vagina. That's the passageway. So what if you have a patient, let's say, who has cervical cancer, and she's had a lot of surgery on the cervix because of past history of cervical cancer or dysplasia? That may really affect her ability to dilate. Scar tissue. She's lost scar tissue around the cervix. It may not dilate as it should. So everything else in labor may go smoothly. But if her cervix doesn't dilate, then we become very concerned. So someone who has a history of a lot of cervical surgery / scar tissue, we're very concerned about her ability to dilate. Size of the pelvis. How big is the patient's pelvis? Again, it comes back to the relationship between the head of the baby and the size of the pelvis, right? So does the mom have at least an average size pelvis? Remember, again, on chapter, I think it's chapter 3, we talked about the different shapes of pelvis. I thought you didn't have to learn them, but there's gynecoid, android, several different kinds. And again, depending on what shape pelvis the mom has, it may be easier or more difficult to have babies. You've probably heard the expression, "Oh, she's made to have babies." She's got baby hips, or whatever you want to hear people, say. It has nothing to do with the hips. It's the size of the pelvis itself. That's where the issue is. And maybe someone has a very normal, average size pelvis, but they have a 10.5-pound baby. So through no fault of mom's own, unless it's from diabetes and she ate too much sugar. She has a good sized pelvis, but the baby's just too big. So again, it comes down to proportion. Cephalopelvic proportion versus disproportion. So again, we're showing the pelvis here, the different parts. The most important thing to remember is just those ischial spines, because that is where the most narrow point is. Remember, the coccyx will not play a part in terms of the ability for mom to have the baby. It is very uncomfortable to have a fractured coccyx. It has to heal. A lot of times those women will be sitting on one of the little soft donuts for a few weeks, but it will not impede the baby's progress. Powers. Number 3, the third thing is powers. The powers are the contractions. How's the baby going to get out? The baby doesn't come out without something propelling it down. If it's been in the uterus for all these months, what's going to make it come down and come out? It's the powers or contractions. So the uterus is a muscle. It's a hollow muscle, right? It's holding the baby inside. It's a hollow muscle, and muscles contract. And this is a smooth muscle, obviously. You have no power over your uterus to contract or not contract. The powers are the contracting of the uterus. It's almost like a tube of toothpaste being squeezed both from the top and from the outside in. So that's what contractions are doing. They're pushing down from the top as the fundus of the uterus contracts, or top of the uterus, and then from the sides it also pushes down as it squeezes in. So there's two sources of pressure there. Those primary powers, or those contractions, cause dilation of the cervix and effacement or thinning of the cervix. And I'll show you some pictures of that in just a minute. So dilation is the cervix is basically closed, or a fingertip at most dilated, and then it gets more and more dilated until it's 10 centimeters. And at that point, the baby can come through. Before that, the door of the uterus or the cervix is closed. The door has to open enough for the head to fit through. So first it has to get thin because it's very thick at first. That's the effacement. And then it has to dilate. And then when the patient's somewhere from 8 centimeters on to 10, the Ferguson reflex begins. Anybody know what that means? You know what the Ferguson reflex is? It's that unbearable urge to bear down that a woman has before she has a baby. So you've probably all seen movies, and those of you who've seen videos that I've had you watch, and I think I need to push. I feel like I need to push. It's an overwhelming, uncontrollable urge to push. That's the Ferguson reflex. That happens somewhere around 8 centimeters to 10. Now, what's going to affect, and that Ferguson reflex is a good thing, because if the patient needs to push, they're going to push, and they really can't help it. It's an urge, it's a reflex. What impairs that reflex? An epidural. So you put an epidural in, the patient has either no sensation or minimal sensation, and they either don't even feel any urge to push at all, or it's very minimal. So this is where an epidural really has a negative effect. You lose that Ferguson reflex altogether, I'd say this is my opinion, about 75% of the time. The patient doesn't have it at all. And then the other 25% of the time, it's very how strong they have it. So if we have a patient that has an epidural and still feels a strong urge to push, that's like the perfect epidural. They try to dose the epidural so that they're not too numb, because we want patients to feel that urge. They can't effectively push. If you can't feel anything, and someone says you need to try to bear down, like you need to have a bowel movement, you can't do that if you don't have that feeling. It's impossible. It's the same way pushing a baby out, because you use that same muscle to push, just like you're having a bowel movement. That's what it feels like. It feels like an urge to have a bowel movement. It's the head that's pressing down in that area. And so that Ferguson reflex is very important, and this is one really big side effect of the epidural that is a negative. It takes that away most of the time. So in order to get the baby out, the mom does all, the labor is a lot of something happening to you. You're not controlling the labor as mom. It's happening to you. The contractions are coming. You're laying there. You're trying to get through them. But it is a little bit of a passive process for mom to have the contractions. Now, when the Ferguson reflex starts and the patient becomes 10 centimeters dilated, now that is the active part. The mom actively bears down, pushes with contractions, only with contractions, not when she's not having contractions. And between the contraction and her bearing down efforts, the baby is born. So you can see if the mom doesn't have that, it's a two-part thing. You got the contractions and you got the mom's efforts. So if you have the contraction, but you don't have the mom's efforts, it's going to be really hard to get the baby out. So what do we do? What do we do if the patient has an epidural and they can't feel anything? What do you think we can do? What's our answer to that?
Yeah, where do you give them Medicaid? I don't remember.
Well, about all you can do is turn it off.
Yeah.
What'd you say?
You have to be there with them to coach them when they're having a contraction.
Well, you do. Well, you most definitely do. But what you'll see is the effectiveness of those contractions. You have to say, oh, it's time to push now. Come on, push. And they don't really know that they need to push. And so their effectiveness is minimal at best. So they get all tired out and not much progress. So what we do oftentimes is just turn that epidural down and turn it off. And we call anesthesia and say, she can't feel a thing. And so usually we'll turn the epidural off for an hour, let her rest. And usually if they know you're turning it off, they'll freak out. If you're upset with you, they'll be freaking out. But, it's kind of like, okay, how much longer do you want to be pregnant? Because here we are. And, the only way out is through it. So we turn the epidural off until the patient gets some sensation back and then start pushing again. So usually it's not beneficial to try to push when there's no sensation. So a lot of times we'll turn the epidural off, let the patient rest an hour, and they'll get some passive descent of the head just from the contractions, but you're not going to get the baby out without, except in very rare circumstances, you're not going to get the baby out without mom pushing. It's just not going to happen, especially with the first baby. So we most definitely would have to turn the epidural off. Usually most times at about an hour she can start feeling the urge to push, sometimes sooner than that. So this is the uterus, and the baby's, this is the uterus, this is the cervix or the door, the baby's inside there, and this is kind of non-pregnant uterus. You see how thick the walls are here. This is one that is full with the baby, but look how thick the cervix is here. Now, it has to thin or efface, and it has to dilate. So it's really like maybe a fingertip here. Now, see how it's starting to get thinner on the sides, and it's starting to dilate, so it's maybe a couple centimeters. Now, it's even thinner on the sides. So as those contractions keep coming, this area thins out and it dilates. The patient here is maybe 7, 8 centimeters. And over here, you see the cervix, the cervix is very thin right here, and it's completely dilated. So it starts out very thick and very narrow, and as the contractions keep coming, it gets thinner and opens more. And when it's at 10 centimeters, it's completely open enough so that the baby can fit through. And that's what we're looking at for effacement. That's the thinning. So it's a two-part thing. You have to have dilation and thinning of that cervix. And then as that happens, the baby descends, and then we assess station, and the baby's head descends.
Is that something that would be checked like visually or like by feel?
You have to feel. You do an exam, you do a cervical exam, and you feel the dilation, and you also feel the effacement. So you can feel how thick it is and how thin it is. And we always laugh when somebody says, oh, she was 60% and now she's 65% effaced. Like, you got some sensitive fingers there. 5%,
Yeah.
So usually what you see most of the time is we'll say it's thick to start out with. And then maybe it's 50 to 60%. Then it's maybe 80% and then 90%. So usually it just goes in increments of 15, 20% based on, it's a very subjective, I will say. It's a very subjective finding, much more so than dilation. Dilation is a specific number. We actually have this little chart at the desk. So you can check the patient if okay, well, the cervix is this much. What does that mean? You come back out and look at the little chart. Okay, that is 5 centimeters. So that's a more objective assessment than the effacement. So effacement is very subjective based on the examiner's assessment. Station is more objective as well because, again, you're measuring from the ischial spine, about a centimeter, above or below the ischial spine. So that's more objective. But effacement is very subjective. Okay, so now we're down to position. So we talked about all the 5. We've got 2 left: the position and the psychological response. Position. I said that position made a big difference in the labor process. Position affects the woman's anatomic and physiologic adaptations to labor, for sure. So gravity is gravity. Sitting up, walking is more effective than laying flat in a bed, for sure. Frequent changes in position of the mom does a couple different things. It relieves fatigue. If you lay in one position all the time, how do you feel? You feel really tired of that position, right? So movement is good. The more you can move, the better off you are. It increases your comfort and improves circulation. Obviously, you know all the things about, changing positions and mobility. You learned that in the first semester. So just those things improve her comfort, her ability to tolerate labor. And in addition, if the baby is in a position that we don't like, the best way to get the baby to move is to move them off. Now, I'm talking about the position of the head in terms of anterior, posterior. If the baby's breech, you can have her run to Ohio or back. It's not going to change anything, obviously. It's not going to make a difference. But if we're just talking about the position of the head, you might get that to change or move based on position. So when I say
move by flying on ice pack.
What?
I said I got my baby to move by flying.
Well, that might work. Yeah, that might work. And
he didn't like the ice, so he moved.
Yeah, heat and ice are often used for comfort, but I can see how that would be beneficial as well. So if a patient comes in early labor, one of the best things we could do for her is to say, walk. If the baby looks okay on the fetal monitor and there's nothing else going on that's bad, go walk, move as much as you can. So it's when our patients come in and we stick them in the bed and put them on a fetal monitor because it makes us feel better to see the baby's heartbeat and leave them on that monitor and not let them up. That's when we start getting these malpositions of the head. So we see them a lot more than we used to because of epidurals. Because once we put in epidurals, obviously, we have limited ability to move the patient. So it's another reason why we tell patients to stay at home. If there's nothing wrong and you have had a normal pregnancy and no problems, stay home as long as you can. Don't come to the hospital until you have to. Because, those of you guys who watch The Business of Being Born know that when you get to the hospital, that's when things start to happen that interventions that make us feel better as, nurses and doctors, but are not necessarily what's best for mom and baby. So changes in position are the best thing to do to help the baby to move and get in the most ideal position. Again, we're talking about getting the head to move. We're not talking about getting the baby to turn, like I said, from breech to vertex. That's not going to happen. And then we didn't talk about psychological responses there, but I hit on it a little bit earlier. But just remember that it does have an impact. I really already talked about it, probably said everything I need to say. Depending on the patient's background, their history, their experience, or let's say the patient, first baby, they had a fetal demise and their baby died. That's going to impact their experience, especially if it was related to childbirth. They're going to be scared to death. They're going to be freaked out. They're going to need a lot of comfort and a lot of instruction and reassurance. So look at the patient's background, experience, and history and determine if there is a psychological response that's going to impact her pregnancy. Again, things that are most likely to do that, like I said, a previous loss, sexual history of sexual assault, age, experience, background. All those things might affect the psychological response of the patient. So we need to look at that on an individual basis. All right, so let's go just a little bit further and then we'll take a break. So now we talked about the 5 P's and how they affect labor and birth. So now we're going to talk about labor specifically. We're going to talk about the stages of labor in a minute. So labor is the process of moving the fetus, the placenta, and the membranes out of the uterus and through the birth canal. Remember, you've got the baby, you've got the placenta, and then the membranes are what's holding all that amniotic fluid in. So the membranes sort of hold it all together. They surround the placenta, they surround the baby, and it's the big balloon, within the big balloon of the uterus, that the baby is inside, in amniotic fluid. So various changes take place in a woman's body that occur days and weeks before labor begins. So way before labor starts, there are things happening in a woman's body that are preparing her for labor. So that's why patients, when we talk about preterm labor in a separate chapter, we can start to see those signs early. If a patient's very early, like maybe, let's say 28 weeks or something, you start seeing some of those signs happen that is concerning about the possibility of preterm labor. So what are signs of labor, that labor is going to happen? There's a term called lightning, or you may be more commonly aware of it as the baby has dropped. Have you ever heard somebody say to a pregnant woman, oh, your baby's dropped? Or maybe she says, I can breathe so much better now because my baby's dropped. So the baby, as it gets bigger and bigger, it kind of rides up under the rib cage, and it's very uncomfortable, and some women are even short of breath. And for primates or first babies, so primates are first babies essentially, and multiparous are subsequent pregnancies. That baby drops usually a few weeks before labor starts. So the baby drops, and that's what causes a first-time mom to start effacing and dilating. The pressure of that head on the stomach starts that dilation a little earlier. Now, for multips or people that are having the second, third, or fourth babies, their baby stays up high until time for labor. And then what happens is when it does drop, like right at the beginning of labor, then they go really fast. So for first babies, it's a long, drawn-out process. It takes weeks. For second, third, fourth, subsequent babies, the head drops kind of very suddenly right before labor starts, and then it goes really quickly after that usually. So lightning or dropping of the baby is a sign of labor, but for first babies, labor can still be weeks away. For subsequent babies, it's probably going to happen relatively soon. Bloody show is a loss of just a discharge of bloody mucus. Now, I've had people come in all the time that think that they're labor because they said, I have a bloody show. That just means labor's probably going to start within about a week. Could be tomorrow, could be tonight, could be a week from now. So yes, it's a sign, but it is very unspecific. We also see in some patients early dilation. You've probably all heard of people that are walking around 2 or 3 centimeters for a few weeks. In some patients that happens. In some it never does. Some patients stay closed, literally, undilated until their labor begins. Some patients walk around 2 or 3 centimeters. Everybody's different, and really, there's no specific sign to that, or it doesn't necessarily mean anything. It just happens different for different people. Nesting or rush of energy is often present the days before labor begins, a well-known phenomenon without an understanding of the cause, but mom just feels this urge to get everything done. I've got to get my backpack. I've got to get the baby bed set up. I've got to get all these baby clothes washed. They just feel this overwhelming urge to get these things done because they know, but something in the body tells them they need to do this. And usually nesting is something that occurs in the days to a week before labor begins. And that's a very, again, subjective thing as well. So the onset of labor, we can't ascribe it to a single, I can't tell you this is the one thing that causes labor to begin. Because there are multiple things that happen. It's a very mysterious process in the body that nobody really understands for sure. We do know that the pituitary gland plays a very big role in starting labor. Now, what tells the pituitary gland to start releasing oxytocin? I can't tell you. It's different for different people. And we really don't know, but we do know that at some point the pituitary gland starts to release oxytocin, which is what causes labor to start. Pitocin that we give you is the synthetic form of oxytocin. That's our, lab-made oxytocin. But the body releases it naturally, and when you go into labor on your own, oxytocin, is released. You start having contractions. Those contractions cause the cervix to efface and dilate. And one thing that we do know, along with one of the things that does cause the pituitary gland to start releasing oxytocin is when the body deems that the uterus is full. Remember I said when we talked about polyhydramnios, what are we concerned about polyhydramnios? What did we say that is a risk that is associated with polyhydramnios? It is a lot of fluid, but what does that fluid cause? Premature labor, right? Preterm labor. Because the body feels like the uterus is full. That fluid makes the body feel like the uterus is full. Therefore, patient starts to contract. Your body says, oh, it's time to empty. It's full. When the baby becomes large, if you have twins, triplets, quads, any kind of multiple gestation, when the body gets to a certain point, the uterus gets full to a point, the body's going to say you need to empty. So you're going to start in the labor, even if the babies are not quite ready yet, because the body senses that the uterus is full. Stages of labor. There are 4 stages of labor. I'm not going to ask you, I'm going to talk about the substages, but I'm not going to ask you what those are on the test because, again, your textbook talks about kind of doing away with them, and I'll explain why after the break. But you are going to need to know the stages of labor. I just want to test you on the substages. There are 4 stages. Let's do the first. Let's do the first one, and then we'll take a break. The first stage is the longest by far. The first stage is the longest stage by far because it's from the beginning of labor to 10 centimeters dilation. So that could be anywhere from a few hours to 20 hours, and you probably all heard somebody say, how many of you heard somebody say, I was in labor 69 hours? Probably not. But they may have thought that, but truly, labor usually, 24 hours is about the max if somebody's really truly in labor. So first stage begins with onset of contractions and ends with 10 centimeters dilation, often called complete dilation. If you hear the term complete, that means they're fully dilated, they're 10 centimeters. The substages are latent, active, and transition. And what I'll do is I'll talk a little bit about them after the break, but again, I won't test you on. Your textbook says they're doing away with them, and the reason your textbook says that is but your book, which is I think that's what it's sad, but your book says so many people have epidurals now that those substages are not identifiable anymore. The reason they're not identifiable is because they're identified oftentimes by behaviors. If you have an epidural, you don't see those behaviors. For example, most people know about transition and how women tend to get very mean and angry and frustrated during transition. That's when if they're going to curse, that's when they curse. If they're going to yell at somebody, that's when it happens. But with epidurals, it kind of changes the behavior because they don't have those, they don't go through those stages the same because of their pain relief. So it's harder to identify those stages. So I'll talk about, after the break, I'll talk a little bit about the substages, but I will not test you on. If you just know first, second, third, and fourth, you'll be okay. Okay, go ahead and take a break, take a 10-minute break, and then we'll finish that part up.
I can't do this right now.
Yes, yeah. He's just measured that down for us to help us to fine. average age of baby.
Love that shirt.
Yes.
That's so
Yeah,
true.
you're too small, they're talking about from here to here. Yeah. Well, maybe
31 minutes later.
sometimes they say that and then they get surprised, like, so, again, it's a judgment, it's not an absolute.
Huh? No?
I just heard it. Yeah, my chest is high, but you said you're.
Tired. Oh, it's close. That's funny.
I need to go home and go to sleep. I so didn't want to get up at all this morning. I laid there and thought really hard about it.
Yeah.
But sure, I guess I probably should.
Maybe then they propagate hammer out, so it's a subjective thing. You want something
So
right.
we're supposed to have a meeting right after class for SNA. Right after class, like at 11 o'clock. If you want to join. Mandy just told me right before class. Like, she pulled me over to the side.
Never.
What am I supposed to? I know you want me to talk about these t-shirts. What am I supposed to just talk about it?
Just, I was gonna say,
Because it's first, my.
I mean, am I asking? Am I telling? What am I doing?
I don't have any, I guess, telling. I guess.
Okay.
I mean, because, well, I mean, like, you're not doing it through SNA. You're doing it
Well,
yourself, right? Or do you want to do it through SNA?
I know
Do
that.
you want help selling them? Or do you just want to do it, like, on your own? Like, do you want her to make t-shirts and, like, set out front, like, with them?
Oh no,
Or
she's not
she'll
gonna do
just
that.
do
She's
it?
just gonna
Okay.
take orders.
She's gonna take orders.
So like
So just
once we pick, I mean, I guess I'll pick somebody. We'll pick like 3 designs or whatever. Not really. So I guess I'll just print. Once I pick 3 designs, I will print an order for them, and I will cut a
that we
piece.
discussed. Those
I will
ones were
cut a piece of
good.
paper in half, and we'll have 3 things and your information. And you fill it out,
Bam. That works.
and then and I'm gonna give big stuff to Miss Amy.
Yeah. It is.
I'm over her.
I really like her, and I really think she's trying, and she cares. I just don't understand the disconnect.
From the essay. Like, what does she have against, like, I mean, because whenever I was talking to her the other day about it, on the hallway, like, she really acted like she is completely against the SNA.
Because she ain't a fan of it.
Like, I mean, I'm not gonna
Because,
ask
like,
her.
I don't know why, but I mean, she like that's what she told us. She's like, y'all don't have to join. She's like, you just have to raise money. She's like, because you have a nice pin
And
it.
she told me
I
for
know she said that.
Miss Hammond was on to me for saying that in front of the class. She's like, why did you say that? And of course, I'm not gonna get in trouble for it. I was like, I didn't say it. I mean,
Hack me, she said to say it.
and she said it right there in front of everybody. So it's not like I was telling on her, and I feel like I was tattling on her. Like, that's how I felt in the moment. But I was like, I'm not getting in trouble for it. Because I didn't do it.
She made it very
To
clear.
do something.
I mean, just our clinical group in general, she made it very clear to us that it was on us to step up and do something.
I know.
So we're like,
So we're
okay.
trying.
I
And
wouldn't
then,
So like I
either,
said, Abby's making headbands.
Abby's not.
She's not
gonna
gonna
be doing it.
Oh,
I mean, she's still gonna do it because I told her that I was interested, and
oh, she knows I want them because I want
She
Dr.
said she's
Dog
still
and I
gonna
want a
make
white
'em.
one.
She said she's still gonna make them, but she's just gonna make them for like us. You know what I mean? Like, she's just gonna make them for fun because she doesn't want it to be a job.
I still have to
That's
freaking
okay.
take them one for class.
The headbands. I was like, I want one. I seen a nurse the other day at work with one on that had the stethoscopes and the blood bags and the needles and stuff on it. It was the cutest thing ever. It was white and pink and blue.
You what? Mine doesn't necessarily look good, but it keeps my
I'm not
hair
even
from
worried
being
about it.
all like everywhere.
They have both, I think, Stacy.
No, I think I'm just gonna transfer out completely.
Transfer out to where?
What? No, not from here. No.
Talking about work.
I'm talking about work.
Where do you work at?
The OR at Memorial.
That's where
Yeah, I know. Well, like I said, I think I'm gonna transfer out. It really isn't. Like, no, not at all. Mm-mm.
And what do you want to do?
Me?
Yeah.
I don't have a dark blue.
Okay. What do you want? Surgery. Oh yeah, I remember you saying that now.
I like surgery, but
They're
Mhm.
asleep.
yeah, you have a whole room full of people.
That's my thing though, is like because some surgeries take so long. My attention span's not that long.
Yeah, I could not.
I would get bored and like fall over.
Yeah, and they
Oh, so you don't have to stand there the whole time. Somebody will give you breaks. Oh, well,
yeah,
see,
you can
like,
just pick up your
everybody
phone and
that
say I have to pee, and they'll be like, okay, be there in a minute.
Okay. Well, shit. I pee a lot though sometimes.
Mhm.
That's nice.
Like we have specific people that do rounds for breaks too. Like, because they're constantly like, have you had a break? Do you need a break? Do you want a break? And I mean, sometimes I've only been there 15 minutes.
That lady.
I'm like, I just got here.
Have you ever seen her before?
I've seen her getting out of her car.
Is she not the one in the fourth semester, maybe? I don't know. I've never seen her before. I've seen her coming down the hallway.
I literally
No,
can't
it's
do it
not.
anymore.
Oh, I guess he's doing
So I don't
another.
even know
Who
how to
needs
do
extra
that.
classes? I need nothing now.
I don't know where I
Hopefully,
want
I don't have micro.
to go past micro.
The last two. So you guys, as you guys are aware, microbiology is a co-requisite for the fourth semester classes. So if you haven't had it yet, I have the forms here for fall. The school is not going over the summer, but Jared, you know somewhere that is, right? New River? Is it online?
Yeah.
So as a precaution, I would go ahead and sign up for one of these classes, because at the end of the day today, after veterans are registered, the registrar will go in and register you guys. So if you want to take it at either New River, and Marshall usually does it in Taze Valley. You know, that's what you guys want to do. By all means, do it over with the summer, because it's kind of busy in the fourth semester. But one of these classes is on Monday, like from 1 to 3:45, so it's right after you get out of SEM, and the other one is on Wednesday at the very same time. So who does not have microbiology yet and need one of these forms?
And it's just micro, it's not micro lab, right? That's required.
It's just microbiology. So you want Monday or Wednesday?
So make sure, even if you think you're gonna take it somewhere else this summer, sign this anyway. You can always drop it.
Can I get your signature on it before I can take it back to the veterans office?
Yeah. Actually, that's the list of all you want.
Okay.
Raise your hand again if you need one.
Monday or Wednesday?
I guess Monday.
Anybody else? On this
Thank you.
side? Anybody?
I'm not.
Yeah, you kind of have important things to do.
I love seeing sunshine. I'm ready to be out of here and go sit in it. It's supposed to be like 70 today.
It's supposed to be warm all week, isn't it?
Yes.